Hello everyone, my name is Wilmer Palacios and I graduated from College of the Canyons in 2017. I currently work in the medical and cardiac ICU in Fresno, California. I am excited to be here today to help you learn about a condition called benign prostatic hyperplasia and how to care for patients after a surgical procedure called transurethral resection of the prostate. However, I would like to tell you about my first experience caring for a post-urethral resection of the prostate patient. I still remember that morning very well. I had just finished my 6 week of orientation in the medical surgical unit. As I was receiving report for one of my 5 patients, the night shift nurse was like, "You better be ready for a busy day. Your patient had a TURP procedure and they were placed on continuous bladder irrigation." At that moment, I felt lost. I am sure Professor Klein had lectured on the topic in nursing school, but let's be honest, there's just so much to learn and study in nursing school that I have forgotten most of it. As I walked towards my patient's room, I could hear him screaming in pain. I felt anxious. As I turned the light on, I noticed bloody fluid spill all over the bed and the floor. I was a bit scared. The scene appeared to be straight out of a horror movie. Before we proceed with lecture, I would like to go over some learning objectives. By the end of this lesson, students should be able to: number one, describe the pathophysiology or BPH and TURP procedure. Number two, evaluate patients for possible CBI obstruction based on signs and symptoms, assessments, and intake and output calculations. Number three, identify two of the most common complications post-TURP procedure. The prostate is a small gland, usually the size of a walnut, located underneath the bottom of the bladder, and it surrounds a portion of the urethra. The prostate enlarges as men age, leading to a known cancerous condition called benign prostatic hyperplasia. As you can see in this picture, the enlarged prostate obstructs the bladder neck and urethra, causing incomplete emptying of the bladder, leading to urinary retention, frequent urination, and urgency. Urinary retention may lead to complications such as urinary tract infections. The prevalence of BPH increases with age. In the United States, nearly 80% of men older than 70 have some degree of BPH. It is also the most common surgical intervention in men older than 60. I'm sorry guys, but BPH is in your future. The pathophysiology of BPH is not well understood. However, it is widely speculated that an excess of certain hormones causes the prostate to grow. Some studies have shown a high correlation between DHT levels in the blood and enlarged prostates. As men age, less testosterone is found in the blood, creating a larger portion of estrogen. A high level of estrogen has been documented as a marker for BPH. In general, mild BPH is treated with medications. However, as the condition gets worse, surgical intervention is the only treatment. Although many procedures can alleviate symptoms associated with BPH, a surgical procedure called transurethral resection of the prostate is the gold standard treatment. During this procedure, a stethoscope is inserted through the urethra and the portions of the prostate tissue that are compressing the urethra are removed. In this picture, you can see the before and after results. Once the obstruction is removed, urine can flow without issues, and symptoms associated with BPH improve or disappear. At the end of the procedure, the surgeon places a 3-lumen Foley catheter to prevent complications such as, urinary retention due to blood clots. Continuous bladder irrigation is a method used to maintain catheter patency and reduce complications associated with urinary tract obstruction. It allows for the free flow of urine by flushing tissue, clots, mucus fragments, or sediments, which are common. As the nurse, you will be responsible for managing the continuous bladder irrigation. Therefore, it's essential for you to recognize the equipment that you will be working with. The first item is a triple lumen catheter that allows for the irrigation solution to flow into the bladder through one lumen and flow out through another. The third lumen inflates the balloon that holds the catheter in place. As you can see in this picture, there are 3 ports in this catheter. The irrigation port allows for the continuous irrigation or normal saline to continuously flush out the bladder. You will also need 2 specialty size irrigation bags or normal saline. They are usually around 3,000 to 4,000 ml. You must ensure that any normal saline being irrigated though is at room temperature to avoid possible bladder spasms, which could lead to pain. Avoid using sterile water because it could absorb systemically and lead to fluid and electrolyte imbalances. Normal saline is an isotonic solution and doesn't get absorbed systemically. You will also need a bladder irrigation set or tubing, which has a wide port to allow for 2 bags to be connected at the same time. However, only 1 bag will be infusing at a time. Finally, you will also need an IV pole to hang the normal saline bags. Okay, so now let's practice what we have learned. So the nurse is observing a new grad nurse preparing to start continuous bladder irrigation on CBI on a patient who underwent TURP procedure. Which statement, if made by the new graduate, indicates an understanding of proper irrigation solution selection? We have answer A, normal saline with 5% dextrose. Answer B, sterile water to avoid infections. Answer C, room temperature normal saline. And answer D, tap water to avoid infections. So I'm going to give you guys a few seconds to think about the answer, and then I'm going to explain it. So the answer here is C, normal saline should be used for continuous bladder irrigation because it is an isotonic solution. Sterile water is easily absorbed into the systemic circulation, leading to fluid and electrolyte imbalances. Finally, dextrose should never be introduced into the bladder. So once the setup for continuous bladder irrigation is completed, it should look like the picture shown here. The only difference is that you will have 2 bags connected instead of 1 bag using the wide port tubing. Once everything is connected, you will open the flow clamp on the irrigation set and set the rate as ordered. Usually the order will stay something such as titrate output pink to clear. You can adjust the rate by adjusting the clamp over here. It's located underneath the drip chamber on the infusion set. Do not let the irrigation empty completely to prevent air from entering the system. Check the outflow lines often to assess for kinks to ensure that the solution runs freely in and out of the bladder. Measure the outflow volume accurately. It should always exceed the inflow volume to account for urine output. Since the bladder is not irrigated using an infusion pump, an accurate intake and output should be done each time that you change a new bag. For example, let's say that you're using a 3,000 ml bag that was started at 5 a.m. At 7 a.m., you empty 900 ml from the Foley, another 1,000 ml at 9 a.m., and another 1,400 ml at noon when the first bag ran dry. So at this point, you will empty all the urine from your Foley bag and do your calculations. In this case, 3,000 ml was irrigated and a total of 3,380 output was documented. By subtracting the total outflow minus the total, by subtracting the total inflow minus the total outflow, we get a net negative of 380 ml, which is how much urine the patient made. Once you open a new bag, you will have to start the whole process all over again. If your total intake is more than your total output, you will need to assess the patient to ensure that the patency of the catheter has not been compromised. And up here on this slide right here, we have the formula that you will use to calculate your INOs. Okay, so it's time for you to practice calculating intakes and output. So let's say that at 6 a.m. You started a new 3,000 ml bag of normal saline. At 8 a.m. you empty 900 ml from the Foley, another 600 ml at 10, and finally at noon when your bag ran dry, you empty another 1,200 ml. After you do your calculations using the formula, you documented a total of 2,700 ml in total output from 6 a.m. until noon. After you subtract your total output from your total intake, you get a total of 300 ml. However, you now realize that your intake, your total intake is more than your output. However, you remember from my lecture that the total output has to be more than the total intake to account for urine production. You start to wonder, is your Foley occluded? Although there are many complications that patients can have post-TURP procedure, hematuria and catheter occlusion are two of the most common. Although uncommon, the risk of bleeding with TURP is real because the prostate is a highly vascular organ. Bleeding may result in clots, which then could obstruct urine flow and obstruct catheter. Initially, the drainage from the Foley bag begins as reddish pink, and then it clears to light pink within 24 hours. If the output continues to be bright red or bloody, despite increases in irrigation rate, you must notify the surgeon, as it could indicate internal bleeding. Catheter occlusion is also a complication despite the use of CBI. As a nurse caring for these patients, it's essential to understand the signs and symptoms associated with an occluded CBI. If the catheter becomes occluded, you might notice all or some of the following symptoms. Lower abdominal pain is the first and most common symptom associated with patients experiencing catheter occlusion. The pain becomes more pronounced as the bladder fills up. You may notice decreased or no urine flow from the catheter, leading to suprapubic distension. Patient may have urine leaking around the catheter as well. Finally, although a late sign, patients may develop vasovagal symptoms such as sweating, tachycardia, and hypotension. I personally have never seen the late signs. In the event that the catheter and CBI becomes occluded, you will need to assess the system by turning off the irrigation solution and checking for kinks, loops, or clots. Palpate the bladder and note pain and discomfort. Performing a bladder scan may be useful to determine bladder volume. If the catheter becomes occluded, manual irrigation is used to clear the bladder and catheter of blood clots and restore catheter patency. It involves manually flushing a 50 to 60 ml syringe and normal saline. This is followed by an increase in the irrigation rate to minimize the risk of future clot formation and obstructions. If you are unable to unclog the catheter, then you must notify the urologist, as they will try to clear it or replace it if indicated. Now, different organizations have different policies for flushing an occluded CBI. Therefore, it's essential that you follow your organization's protocol. Flushing an occluded CBI is time-consuming. Your goal is to keep it from happening by monitoring the color of your output and to ensure that it stays pink to clear, and by adjusting the irrigation rate as needed. If you notice a color change to darker pink or reddish, you should increase the rate to flush the clots out and to keep them from clogging the catheter. CBI is discontinued once there is a color change in the output collected on the Foley from pink to amber, indicating a reduction in bleeding. The irrigation is then stopped for at least 6 hours to do a trial. If the patient tolerates the trial, then the Foley is removed. If the output changes to darker pink or reddish with black clots, you should restart the irrigation to avoid possible occlusions. Okay, so let's do one last question. So the nurse is receiving report on a patient who is on continuous bladder irrigation. The nurse understands that the irrigation flow rate is adequate to avoid obstructions when answer A, output is the same as input. Answer B, no urine output is noted. Answer C, the patient's urine output is clear as water. Or D, the output is clear to pink. And I'm going to give you just a few seconds to see if you can answer this question. Okay, so over here we have that the answer is D. So the goal of CBI is to prevent black clots from forming. By adjusting the flow rate to maintain urine output clear to pink, you prevent clot formation. No urine output indicates an obstruction, likely from a clot. If the output is clear as water, the rate should be slowed down. The output should always be slightly more than the intake. So, in summary, today we learned about the pathophysiology of BPH and about a procedure called transurethral resection of the prostate, or TURP. We also learned about continuous bladder irrigation and how to set it up. And finally, we learned about how to flush an occluded CBI and how to calculate intake and output. Now, remember my story at the beginning of the lecture? My patient CBI was occluded and it was causing him tremendous pain. I called my educator and she assisted me with manual irrigation after we did pain management for the patient. Finishing nursing school is an exciting time, and by using your resources, such as educators, supervisors, and fellow nurses, you will be successful. Thank you, and I hope that you have enjoyed this presentation.